I have a few cases I can start with. Let's see. All right, you should see myosiris here. So here's a quick fun case. Let's see. So this is a young guy who would present with chest pain, but you can see that his radiograph is very interesting looking. He's got these funny ribs. I learned this term from my resident yesterday. These are called canoe paddle ribs. I've not heard that term before.
Yeah.
But what's kind of cool is you can see this extra interface along the mediastinum. There's like a triple density here. So left atrium, presumably, and then some other thing, and then the right atrium or some combination thereof. And there's this extra bump there as well. So you can imagine where this is going to go. But with expanded ribs, bones in general, and funny looking bones, you think about marrow processes. And this is a CT scan, and you can see he's got all this soft tissue and this mottled appearance of his bones expanding out from it. And so this is a patient with thalassemia who has extramedullary hematopoiesis, but this is one of the more exuberant cases I've seen. We don't see a lot of thalassemia here in Wisconsin. We see some sickle cell, but so we don't see a lot of this. So this was kind of just cool for me to see. But I don't have a sulfur colloid or other scan, but I don't think we need it in this case. This is.
Yep. It's interesting in that case that there's some fat mixed in with the EMH.
Yes, we were talking about that yesterday.
And I've seen these cases involute, with therapy, and the marrow elements will go away, the soft tissue stuff goes away, but the fat often remains.
Yeah, that makes a lot of sense.
Yeah.
You wonder if there's some going on in the liver. His liver is kind of homogeneous. I don't have any other imaging, but or if that's something.
We had one case with renal involvement too, where there was extramedullary hematopoiesis in the kidneys.
Interesting.
So you're right. It probably is involvement in the liver as well.
Yeah.
Yeah.
Cool. All right. This is just one of my other residents told me about this case. This is a trauma motor vehicle crash, and you can see this is the presenting radiograph. So they'd already put a drain in an endotracheal tube, and you can see the aorta is markedly abnormal. It's big. The trachea is pushed way over here. There's the descending there's paraspinal contour here is abnormal as well. But this is by far the worst aortic injury I've ever seen. And classic location. Sorry, let me get the window right. You see the massive hematoma, but this one actually was actively bleeding at the time. And you see a little bit down, all the way down there, and there's even much more bleeding further down in the chest, and then just all the way down here. So as you can imagine, this was not survivable, and there's probably some extrinsic tamponade occurring there. But this is just these patients I usually wouldn't even survive to be imaged, but this is just the worst one I've ever seen. So a complete transection with just massive hematoma. I'm sure there were other injuries, but one of the more impressive ones.
Oh, yeah.
This is the other one I wanted to show. So this is kind of a cool case. So this patient actually presented with conjunctivitis and anterior uveitis. And so you can see all the conjunctivitis, and honestly the uveitis, I wouldn't know what it looked like, but this eye looks very angry, and he's an older guy. There's the other eye there. Yeah, just different images of the eye. And he also had some chest imaging, and I'll get to it. So all he had was this nodule or mass here. It's got some airways passing through it, and then he has an enlarged paratracheal lymph node. But he was briefly in Arizona, and so this is a case of coccidiomycosis, which of course we don't see a lot of here in Wisconsin other than travel. But I've been doing some reading about it recently, and you guys know this because you've practiced out there. But you don't need a lot of exposure. You don't need to be there for prolonged periods of time. Even just passing, I can't remember if we had two patients with cocci at the same time. One went there for a wedding over a long weekend, and that was enough. And this is a good time of year for cocci as the soil's dried out, and so people are outside. It starts to cool off a little bit. But conjunctivitis is part of the valley fever. But one of our medicine residents told me, or actually one of our pulmonologist told me about this, that this anterior uveitis is much less common. There was some some slit lamp images, but I honestly didn't know what to do with them. But the conjunctivitis is definitely part of the valley fever. But so that's what kind of prompted them to look into the cocci, and all the titers were positive. So case of cocci, the lung involvement being pretty minimal. And just while I have another case of cocci that presented at the same time. This is more typical of what we might see with histo, with a dominant nodule here, with some lymphatic nodules draining along it. But the travel to endemic areas for us is sufficient. Okay, that's what I got this week. So I will stop sharing. Who would like to go next?
I can go.
All right.
Go back to Coccidiomycosis here. I'm going to start with this one. So this is a 33-year-old woman who, as you can see, has a fibrosing interstitial lung disease. And her history is really interesting and dates back to shortly after birth. Apparently, she had failure to thrive, ended up with a lung biopsy early on, like less than a year old, and was just told she had obliterative bronchiolitis. That was 33 years ago. And then throughout childhood, had courses of respiratory issues, was, never totally healthy. At various points was said she had asthma, had severe reflux, underwent a Nissen, this and that, and was followed by a pulmonologist elsewhere. And then into her 20s, started to decline further, ended up with another lung biopsy like 3 years ago, and this is all elsewhere, where she was told that she might have LIP, although the pathology wasn't great for that. It just was fibrosis, and we don't have that path here. I wonder how much of that could have been, led to by the fact that she has a lot of what looked like cysts on her imaging. But anyway, she was referred to us here into our interstitial lung disease, and we'll get to a diagnosis because we actually have an answer now. She does not have a history of arthritis. She doesn't have a history of bleeding or any sort of hematologic issues, nor does she have a history of other family members with lung disease. Certainly in young patients, connective tissue disease. I've shown patients with COPA syndrome and these other weird syndromes, but nothing really in her family tree. And you can just see there's not a lot of, there's some traction, but this is really just a lot of like cysts and destruction of lung, architectural distortion, reticulation throughout her lungs. And this was a couple years ago. Now looks pretty much, hasn't really changed. Obviously, this has been going on for a long time. So she was referred to genetics, and they did whole exome sequencing, because like I said, that she had no family history of lung disease. And it turned out that she had a de novo mutation of surfactant protein C. So this is a patient with fibrosis from surfactant protein C associated mutation. And I think that explains her illness from early on in childhood as well. And we had followed a couple families when I was at UCSF, and this is one of those ones that there's acceleration from generation to generation, but this was essentially a form thrust mutation or just a sporadic mutation of surfactant protein. So I think anytime you see something in a young patient, genetic analysis, especially now that whole exome sequencing can be done, is very useful. And this is an unclassifiable type of fibrosing interstitial lung disease. This was from my talk, because I find these genetic syndromes to be very interesting. And this was from a couple of years ago at STR, but I just pulled this up really quickly because I had a couple of other cases in here. And here's one such family. So I imagine this patient may have looked similar to what this one did. At age 21 months, you can already see these little cysts developing. And back then they had ground glass opacities. There's not really a great treatments. They do give a lot of these patients chloroquine, hydroxychloroquine. I don't know what they're going to do with this patient yet. They were considering starting her on OFEV, but that was before they got the genetic results. And then this is another one, and this guy looks almost identical, I would say, to the one that I just showed you here. So very similar looks amongst these patients with surfactant mutations. And as I mentioned, there's genetic anticipation. So this obviously very important if people are going to have children, as the genetic counseling, because their sibling or their offspring will have, earlier onset in future generations. So,
Travis, is it known whether associated with this there's deposition of a protein in the lung?
you're wondering about amyloid or?
Well, just protein of some kind.
Yeah.
Because you've got extensive cystic disease.
Yeah.
I'd have to.
I don't know, and I don't remember. I haven't.
Yeah.
This one I just came across this a couple of days ago and haven't looked back. They did work up for LAM, for amyloid, LIP, everything at the time. They didn't, we haven't, like I said, they haven't reviewed it here. It just said bronchiolocentric cellular and fibrosing interstitial pneumonia. So,
Travis, why is this heritable if this was an acquired mutation?
Well, so in her case, it was an acquired mutation, but it's usually transmitted as, I believe it's an autosomal dominant mutation.
Okay.
In the other patients. So there were families at UCSF that were followed. And like I showed, this case here, this was a man who he was only evaluated after his son had presented and they found out that he had the mutation as a child. And so this patient had less severe disease that wasn't until later on in life onset with symptoms.
Okay, thank you.
All right. And this is quite, I'll make sure I get the right radiograph. Not that one. This is a patient who you can see has big heart not doing well. Ended up, you can see he's got a subcutaneous AICD. He got admitted for cardiogenic shock, and you can see he's got an intra-aortic balloon pump. This is the next day, the intra-aortic balloon pump, and then I will put this radiograph up next to it. And so these, I believe, these two radiographs, this is the newer one over here on screen right, and you can see these were done, over the course of just a few hours. And let's just see what you think.
There's an abnormal mediastinal lung interface in the left para-aortic region, as well as abnormal opacity.
Good, yeah.
Is that a balloon pump in there?
Yeah, this is a balloon pump in there, yep.
Misadventure.
Yeah, well, very good observation. And, this was actually, oops, that's the same image. This was actually recognized, and they did a CT, because Howard, you're spot on there. And you can see there's hematoma surrounding the aorta, and there's a tiny little hole right here, which is not like a little branch artery pseudoaneurysm or feeding any sort of intercostal. And presumably that's where the intra-aortic balloon pump must have dissected or essentially ruptured the wall of the aorta, because you can see this hematoma. I have not seen this as a complication before, but this is iatrogenic aortic injury with a considerable amount of blood surrounding it.
Wow.
And this was just, I think they did a follow-up a couple days later, and you can see it's still there, still has that same little outpouching right there. And then they did eventually, this guy actually got a heart transplant, but before they did that, they put a stent. And as you can see now, the mediastinal hematoma has resolved and the mediastinal interfaces are back to normal. So I have not seen that as a complication of an intra-aortic balloon pump. I haven't really had time to even search the literature to see if it's been reported. But I just, I'll put up that radiograph again, because yeah, you can see, as you said, just abnormal widening here. There's rightward deviation of the trachea. You've lost your AP window, and there's just too much stuff in this area, probably displacing the left bronchus a little, flattening it out too. So.
Yeah, it's very curious. I've never heard or encountered that before myself. That kind of injury.
I wonder what caused the tip to snag in that location, because you'd think the you know, we're talking about the axial part of the aorta, and the tube should go right up the center of the aorta. There's no reason for it to perforate the edge. And I can understand it's perforating the top of the aortic arch because you're jamming it up against that.
Yeah.
So I wonder if that was an intercostal takeoff or something like that, something that some orifice off this thing.
Yep. That's a good thought. Yeah, I don't know. But
Is there any
Maybe
literature that links these counterpulsation balloons to dissection? Not from, but just from like the balloon inflating and deflating?
I will look. While somebody else goes, I can look and see.
Okay. All right, who would like to go next?
I got some, Jeff.
Oh, hey, Seth.
No, it's Peter.
Oh, Peter, I'm sorry. I saw Seth for a minute and then he disappeared. Sorry. You guys have those deep voices.
Okay, so I got quite a few, but mine are all pretty quick. Show 2 vascular, then 3 chest cases. This one is just a quick, interesting, just a nice example of something. So this is a patient. She's a young lady and had postpartum coronary artery dissection. I think she was in her early 30s, and you can see they stented it. And as part of the workup after that, they were worried about fibromuscular dysplasia, so they got this chest, abdomen, pelvis CTA. For whatever reason, they did it with the arterial and delayed phase, and we didn't see any fibromuscular dysplasia, but it's just so this is the arterial phase, and I'll pull up the delayed, and it was just a nice example of where you can see the infarction on the delayed phase. You can see the hypoperfused myocardium in the septum, and
Oh yeah.
a little bit in the free wall.
It's cool.
So just a nice, it's kind of happenstance getting the delayed scan, which you don't really see it. I guess I don't really appreciate it on the arterial phase, on the earlier phase, and then on the delayed you can see the hypoperfusion.
So Peter, does she have coronary disease, or is it due to fibromuscular dysplasia?
So she didn't. I don't know what this case was. A
37.
For the last, I remember. I vaguely remember that. I don't think there was any fibromuscular dysplasia here, and it was just a spontaneous dissection of the coronary. She didn't have any coronary disease.
Okay.
She was young. She was in her early 30s.
Yeah, right, because they stented quite a bit of coronary there.
They stented both, and I don't remember if it seems like they stented the circ as well. I don't remember what the details of that were. I just remember the CTA was just kind of interesting. Yeah. Okay, this is a very straightforward case, but I just hadn't seen one of these either in a long time or ever. But they are reported. So this is a patient with a left lower lobectomy, but I did notice they had clot in their stump there. Do you guys? I've seen a lot of lobectomies, but I don't recall seeing one of these. It's post lobectomy thrombus.
I mean, I've seen them in arterial stumps, but I don't recall seeing in a venous stump. And it's usually after a pneumonectomy in the arterial stump, because usually when they do a lobectomy, they don't leave much of a stump.
Yeah.
Right.
Yeah, I looked this up, and there are definitely reports. So there was a paper, and I guess I didn't include it, but they talked mainly of the left superior pulmonary vein. And this one's in the left inferior vein. So, just found it interesting. Just had never seen it before. Okay, and then the other 3 cases are all right upper lobe inflammatory processes that all came within a few days of each other. I'll show this one.
Let me know if that is.
Oh, this one came today. So this is this patient. Yeah, this patient has a history of hyperlipidemia and COPD. So here's this large consolidation here. It looks like an abscess with central kind of fluid density almost, and some cavities there. And here's the periphery of the mass. You can see some ground glass. And then, so this actually was biopsied, and it came back. It was found to be actinomyces. And here is a month later, post-treatment, we have a fibrocavitary lesion. There was no necessitans here.
The patient had bad teeth.
Good. Yeah, good question. I didn't check that, but yeah, there's a good chance.
That's an impressive actino abscess there. I'm surprised that it didn't extend through the chest wall, given how big it is. But
yeah. And yeah, it was confined by the I can show the coronal, but it was confined on the bottom by the fissure. And I know for nocardia they like to say it's non-segmental consolidations. I don't know about actinomyces, but I'm assuming it's probably similar.
it's usually just a big necrotic mass, and it's kind of molders along, and it can generate a lot of fibrosis. I don't know about so much in the lungs, but in the head and neck and in the pelvis, it can cause like a chronic tubo-ovarian abscess or alpinitis with like lots of like really hard fibrotic tissue.
Yeah, well, it definitely generated some fibrosis here.
Yeah, there. The lung doesn't collapse down to fill the cavity.
Yeah.
That's really cool. That's the biggest one I've ever seen.
Okay, so I'll show another one. Another right upper lobe. Show this one. This one. So this is a kidney transplant patient. So right upper lobe mass, and then some adjacent tree and bud. It seems like the vessels are a little bit dilated there also. This came back as invasive aspergillus.
Yeah.
I'm sure, I know you guys have all seen it. We see that relatively common. And then this one was interesting. This I had never seen before.
Okay, thanks.
So I will show so this is the initial radiograph from patient from May, so nothing there. Another radiograph from July, so you can see this patient, cavitation there. This patient is a liver and kidney transplant. So obviously, I think my colleagues read this, but of course they were worried about a cavitating infection with fungus. Fungus is a possibility. And so that was in July, and then here's the CT. So this is what the CT looks like. So the differential didn't really change. Obviously, infection is at the top of the list. And this was biopsied, and here are the results of the biopsy. This is actually, they did a lobectomy here. So the diagnosis was xanthogranulomatous inflammation.
So it says chronic Klebsiella, did they actually culture any organism?
Previously, but that was in the urinary tract.
I see.
Yeah, so she had sepsis, urinary sepsis with Klebsiella, and then somehow developed this xanthogranulomatous inflammation in the lungs, which I'd never. There are obviously case reports of it. I never heard about it. I mean, in residency, I remember studying XGP, which is xanthogranulomatous, you know, in the kidneys, but it can happen in the lungs too. And I'm not sure what, I mean, in the kidneys, I think it's usually associated with an infection. But have you guys seen that before?
Nope.
I'm not sure. No.
Teuton type giant cell. Interesting.
Yeah, so I looked that up, and unfortunately, I requested they send me the path, but they haven't gotten back to me yet. But these 2-ton giant cells. I Googled that and I should have included an image of it, but those are those are like the characteristic cells that you see with xanthogranulomatous inflammation.
Oh,
But yeah, I can send this. And then as far as all the tree and bud, maybe it's just the same process.
just a bronchogenic spread, perhaps.
Yeah, the inflammation, granulomatous inflammation.
Yeah, it looks very walled off. It's kind of interesting.
Yeah, right. Yeah, right there. The cavity looks very walled off.
Yeah.
So it doesn't seem like a super aggressive, like an angioinvasive. You know,
Mm-hmm.
looks walled off. I agree. I think that's it.
Awesome.
That's all I have.
Thank you.
Thanks, guys.
All righty. Let's see, Howard or David.
I've got a couple, Jeff.
All right. I'll make you the presenter. There we go.
So this man with Crohn's disease has a pretty normal chest radiograph at this point. Maybe a little atelectasis or scar on the bases, nothing too scary. Things did not stay that way. So this is a while later, and he's now has some basal consolidation. It's a particularly big blob out here laterally, but it involves both bases below that as well. And then he had a CT scan, which shows consolidation here, mostly ground glassy in the right upper lung, extending down into both bases. So widespread ground glass abnormality. And this was biopsied, and they detected a lymphoplasmacytic infiltrate of cells and gave a broad differential diagnosis. It turns out that he'd been placed on infliximab sometime before this, and I think they withdrew that therapy and they treated him with some corticosteroids, and this cleared up. So this is a lymphoplasmacytic infiltrate, probably a drug reaction to infliximab.
David, had he been on that drug for quite a while? Do you know, perhaps?
I'll have to check and get the exact timing of the whole thing.
Okay.
So subsequently showed some clearing. Go ahead.
So were they able to determine whether this was clearly a polyclonal proliferation, or did they do much evaluation of it with flow cytometry, et cetera, perhaps?
I will check.
Okay.
I don't think there was any hint that there was a malignant component.
Okay. Because there is the entity of so-called iatrogenic immunodeficiency associated lymphoproliferation, which could be benign polyclonal or even malignant.
Mm-hmm.
So perhaps that's what they were thinking, that there was that causal association.
Okay, well, I've not heard of that one.
They just withdrew the drug and treated him with steroid, or just withdrew the drug, infliximab, that is.
I think he did get a course of steroids.
Okay, and it got better.
Things did get better on subsequent.
Okay. Okay. So there is if he's been on it for a while, there is the entity of immunodeficiency associated lymphoproliferation from the use of a variety of immunosuppressive agents. Yeah, it's a thing.
All right. And let me show you this child, itty bitty radiograph here. Perhaps maybe I can expand this thing. Can I make this bigger? Let's see. Yes. So you can see the relative rarefaction of the lung in this location here compared to other parts here. This, I think, child is just a couple of months old at this point. And here's what CT looks like in this child. We see that there is this abnormal lucency of part of the lung here. And if I give you a coronal view, as long as we're in this plane, let me show you that there's also a cystic abnormality here, the subcarinal region. And I can show you that better here with a soft tissue window. Here is our cystic abnormality in the subcarinal region. Come on, there we are, down here. And let's look at the lung, because there is a mucus plug associated with this rarefaction of the lung. So this looks like to me a bronchial stenosis. It's an upper lung distribution, but it's not, doesn't go all the way up to the apex. It's sort of lateral aspect of that left upper lung. But I think this is a congenital atresia of the bronchus here with a mucus plug distal to it. The other consideration would be congenital lobar hyperinflation. And then I think we have another congenital lesion here in terms of the subcarinal location is probably a bronchogenic cyst as well. So this is Caney's law of congenital anomalies, is that they're often accompanied by another one. So if you find one, keep looking for the other or others. So a small trial there. Okay, those are the...
That's a good one there. Yeah, I agree with you. I think that's probably bronchial atresia given the bronchocele or mucocele.
Right. And it's interesting at this point, this child being so young, it looks as if the mucus hasn't dried out and hasn't become one of those firm bullet-shaped, chronic mucus plugs. It's still kind of liquid and soft looking at this point.
Yeah, he's got, or the child has fetal lobulation of the kidneys.
Okay, he's not that far from being a fetus.
Right, he's a young child. Was it a preemie? I'm sorry, you may have said that.
I don't know whether he's premature or not.
Yeah,
it's an outside case.
That's cool.
Okay, so
Yeah.
I'm sorry you have a defeatist attitude there about that.
Gosh. All right. Thanks, David. All right, Howard, you ready?
Okay. Okay, I have this case. So on the right-hand side is a MINIP image, and I'll just scroll through these because I think pattern recognition, having seen this before, does help in a case like this. So I'll give you a feel for what the irregularly shaped opacities look like. I'll just scroll through the whole thing relatively quickly and then come back up. So down here looks all right. And we begin to get some rather unusual subpleural cystic spaces round about here, which are relatively large, and then there. Then, of course, we get these reticular opacities, and then it's more profuse in the upper lungs. Definitely involves the central lung regions and the peripheral lungs as well. And I'm trying to bring out the fact that in areas like this, I believe there are some additional cystic changes and some architectural distortion of lung. So for just pure pattern recognition, would anyone like to suggest something based on just the appearance of the lungs in a patient like this?
Burned out LCH or something.
Yeah, smoker.
Advanced LCH.
Excellent.
That's
Exactly.
A nice.
It is pattern recognition. Okay, so here we see that this disorder has also involved rather substantially the mastoids, the temporal bones, as you see here. I'll bring this up to show you that. And then also a bone lesion is right here. That is both sclerotic, but also clearly lytic as well, and lytic destructive right there. So absolutely right. So here is the diagnosis, as you said. They biopsied the mastoid tissue, Langerhans cell histiocytosis. Patient is a smoker. This is not BRAF mutation associated. So I think like anything else, not all of them are associated with a positive result for the BRAF tissue, which is what they did look for. But otherwise, yeah, that imaging finding I think is very distinctive for what some people call burned out PLCH, but exactly right. That imaging finding, that imaging pattern. So multi-system involvement in this person. And I'm trying to remember her age.
But Howard, given that it's outside the lung, we can't really attribute this to cigarette smoking. I mean, this has to be
Not
one of the.
necessarily, because it could be the non-smoking multi-system. That's right, histiocytosis.
Even, and there are other mutations besides BRAF that can lead to it.
Okay. Right, good. Yeah.
Yeah, I've only seen, I think 1 or 2 cases of extrathoracic involvement in an adult, and they were both really young, so it very well could have been the pediatric form, just in a 20-something-year-old, but you didn't know how old this patient was.
51 years
Yeah.
at this time.
Yeah. Not a recently former adolescent.
Yeah, no.
That's impressive.
Yeah, you're right. Exactly. Yeah, pretty impressive, isn't it?
Yeah, I think I showed one 5 or 6 years ago that had bad liver involvement, also an adult. But that's the only one I can remember that had extra pulmonary involvement.
Yeah. Yeah, definitely the possible non-smoking multi-system. 1, 2. A couple of quick ones, so let's have a look at this one. This is a patient with a small cell lung cancer. I'll give you a feel for the extent of the disease, which is extensive. And here on the axial section. So a lot of disease, intrathoracic, pleural, probably extrathoracic as well. What was interesting about this one, just from the point of view of a follow-up, is that over time, as she responded to therapy, dystrophic calcium is being laid down in some of the lymph nodes. So you can see it here and there and there and there. And I'm not sure if I've seen that before in small cell lung cancer, as opposed to, for example, maybe metastatic adenocarcinoma or colloid tumors. But clearly a case of dystrophic calcium being deposited in the lymph nodes. Do you guys recall seeing a case like that?
You said small cell?
Small cell.
Yep. No, I mean, usually not. Usually it grows so fast, and then when they treat it, it just melts away. But I've seen adenos develop calcium, but usually with therapy.
Yeah.
That's very interesting.
Yeah. Curious, isn't it? Yeah. I don't think it's just enhancing. I think it is calcium. Maybe I should look at it again, but I think it's not just enhancing those. I think it's calcium. Yeah. Okay. This one is just interesting from the point of view of anatomy. So this is a patient with COVID pneumonia. And I noticed that in relation to this opacity, that at least in its superior portion right there is a very sharp edge. So there is an interface right there, which I could not perceive on the lateral projection, which has got quite a bit of motion and sharpness. But as you might suspect then, if we have that, then, and I'll just bring up these two to show you that sharp edge, which is right here. And that's a great location for the superior accessory fissure. So that's why we have the sharp edge. So scrolling through that region, we can see the additional fissure right there. And there is the consolidation in that location. So the superior accessory fissure separating the superior segment from the other basal segments of the lower lobe. Just anatomy. Here's a really nice example of what Jonathan Chung and colleagues have described in patients with connective tissue associated disorder. So here's a patient. This goes back many years, 2013. Findings of a connective tissue disease associated lung disease, fibrosing, and certainly the imaging findings are consistent with NSIP. And then here is, I think that coronal is going to show it nicely, the three signs that Jonathan Chung talks about. The first is the exuberant honeycombing sign in the lower lungs, and then a fairly straight edge, the interface between the involved lung and relatively normal lung, the straight edge sign. And then, albeit this is clearly asymmetric, the left lung is more affected than the right, but we also have the anterior upper lobe sign, subpleural in the upper lobes as well. So those three signs that are very consistent with fibrosing NSIP in this patient with, I forget, I think it's scleroderma. These are all black and white, but anyway, upper lobe sign, straight edge sign, and the exuberant honeycombing sign in scleroderma.
That's a really nice example.
Yeah, of all of that.
Well, I don't know. There's just a new paper that was published in Radiology Cardiothoracic Imaging. I think Brent Little was one of the, he may have been the senior author on it. And I think there were some people from Emory as well, with looking at patterns of ILD with lupus. And they described some of these same findings. And then they show this another atypical, what they call atypical patterns. One, they talk about the exuberant honeycombing, and then they talk about this island where you get these clusters of like cystic type spaces. So we don't see a lot of ILD with lupus, but
no, I don't.
But it's worth taking a look at.
We just got that email today, right?
Yeah, it just came out. I just saw the I kind of looked through the pictures real quick. I didn't get a chance to read the whole article, but it was really interesting.
Yeah, we see a lot of a little bit here. I think with some of my colleagues wrote that article. We call it lupus lung destruction. There's cystic change in the corners of the lungs.
Mm-hmm.
I actually have saw two cases of lupus with that today.
Maybe you can show them next week or in a future week.
Yeah, I'd be happy to. Yeah,
that'd be great. Because I mean the ones I've seen mostly NSIP like patterns.
Yeah. So that's different from what Howard is showing.
Yeah.
Product NSIP,
right?
Which is just the basis. But yeah, I'd be happy to show them.
Cool.
A lot of those cases.
Yeah, Howard, that's such a nice straight edge sign.
Yeah. Good. Here's kind of an interesting case where I saw it after the event. So the history that I got for this particular patient is that he had some form of respiratory illness and was imaged at the outside institution for presumably pulmonary embolism, which we didn't have. And because these opacities resolved, but not due to PE bilateral, I don't know, presumably an infection of some kind. So this goes back to December. And as does happen, one discovers an incidental, oh, that's interesting too, I forgot about that. But this right here, an anterior mediastinal lesion, and he was referred here and it was taken out. Now I think that's too quick. So when I look at this, number one, it's homogeneous of relatively low attenuation, and it appears soft. It appears to kind of wrap over there like a water bottle, but clearly of low attenuation. And I think that a case like this should be worked up with an MRI, because one can make, I think, a presumptive diagnosis of a thymic cyst. When you see something like that, it doesn't have any solid components in that I can tell, but certainly I think an MRI would be a great way to evaluate that further. It was interesting because I saw that after the patient had that removed. So I decided to follow that up. When I looked at the initial path report, it simply said normal thymic tissue, and I thought that's a bit odd. And then I looked at the surgical note, and there was a description of a needle aspiration of fluid, which was submitted to pathology. But interestingly, the pathology report didn't describe a cystic lesion. So it turns out, and this is, same thing with pathologists, they're not always given the information that could really help them. So when the gross was done in the pathology department, they didn't know that a cystic lesion had been aspirated, and they didn't actually perceive that a cystic lesion was there. So I asked them to look again and provided them the size of this as well as the op note. And when they looked at the gross pathology again, they did in fact find a cystic lesion on the next look. So this is a thymic cyst. And I think that we could have made that diagnosis and averted the surgical removal of it. What do you guys think?
Absolutely.
Yeah, I totally agree. I actually wonder, my bias would be that for a case like this, when you have a contrast enhanced CT, I don't think an MR actually helps in my mind, because and the only reason I say that is because rarely you'll see cystic thymomas that have almost all cysts, almost all fluid and very little soft tissue. And maybe it's just that our spatial resolution isn't good enough, but if we did an MR on this, I don't think it would change anything.
Because you think that this is pretty suggestive of a thymic cyst anyway.
Yeah.
Yep.
And then the question is, so if you do the MR, do you do it now or do you wait 6 months and just ensure stability? Yeah, I mean, I agree that it doesn't need to be taken out. That's for certain. I mean, the only thing I worry about is that you miss a small little solid nodule, that it's a cystic thymoma. But even those usually have more of a spherical configuration, unlike this, like you're showing, which just drapes nicely over the anterior mediastinum.
Right. Yeah, you can definitely make that argument that even an MRI is not necessary, and then you can just follow that up and not even do the MR.
Mm-hmm.
Or follow it with MR in a year or something. I don't know.
Or follow it up with an MR in 6 months, but maybe something
right.
like that. Yeah, I agree with that actually. But yeah, the surgeons are, and this is actually Jean Ackman from, I think she's still at MGH, has written a lot about these thymic lesions and shown a lot of cases, and it's ubiquitous that a lot of these are taken out and proved to either be thymic hyperplasia or thymic cysts, and are not worked up sufficiently before the surgeon just takes them out.
Yeah, and they almost should go to like a thoracic oncology multidisciplinary discussion, or at least with the surgeon and the radiologist.
Yeah, really.
Well, if you put the surgeon in the discussion, they're going to take it out.
I don't know. We prevent a lot of them from being taken out. They're referred to our surgeons for a mass, and then we review the imaging, or we maybe do an MR with chemical shift imaging or something.
Yeah.
To stop it.
I wish I could say, I wish I could say the same.
So, if you look at Reggie Munden's incidental paper, the last time I looked for stuff in the anterior mediastinum or prevascular space, that if it's cystic, they say no further workup necessary. I think, right? That there's not even, there's not even like a single follow-up period.
Yeah.
I'm trying to remember. Somebody's gonna have to fact check me on that, but
yeah,
I
totally
agree.
Not follow it, but I can usually talk them into doing a limited CT or an MR annually, just until they're satisfied.
Yeah.
That still be
for those of you that, For those of you that recognize I hesitated a moment, is that I can't remember if I saw it before, but this is obviously just a persistent left SVC that goes to the right place down there. Okay.
Very nice one. Yeah, and there's no real brachiocephalic vein because you've got equal size vena cava.
So we can argue it's a congenital thymic cyst.
With
you
a
know,
vascular
that's yeah, it's another Caney's law here.
Yeah. Interesting, huh? Okay, let me show you maybe one more. Okay, this is a follow-up, and I will say that, and you guys know I sent this to you because when I initially saw this, a couple of things worried me about a patient like this. One is the process is so unilateral and extensive, but unilateral. And then when I looked at this, I worry about things like that, even though this is in other respects consistent with PE. This kind of lobulation, this apparent scalloped margins worried me for sarcoma. And it's not of high attenuation. I can't say that I see contrast enhancement of it, but the appearance like this really worried me. So I raised that as a possibility, and certainly a follow-up was done and it's completely gone. So this to me is interesting, because usually the clots usually are just much more discrete without those kind of apparent scalloped edges to it, or lobulated, however you might want to describe that. Let me show the coronal actually as well. So this is the initial one. And yes, there's streak artifact there, but this really bothered me for possible sarcoma, even though it wasn't really mass-like. But just to confirm, that went away entirely. And on an ultrasound that was done after I saw the CT, there was a little clot in the popliteal vein on one side. So maybe the rest of the clot, just lots of it all ended up there. But I think if I saw that again, I think I would still worry about it in the next patient I see like this. Is there any reason why anyone would be really, really confident that that's not a sarcoma with this kind of appearance?
Yeah, I think it's just that you have the more tubular portions, and I
As
always
well.
wonder how much of this is in situ clot that just forms on the initial embolus.
Yeah.
It gives it more of that mass-like appearance.
Yeah,
The
and
other
you
thing
do sarcomas expand
that
the vessels quite a bit, and you frequently see big bronchial arteries.
it's also possible that the fat part of this clot is coiled up, thinner tubular portion that's just sort of bunched together, that it folded up there.
Yeah. But completely gone, which is so nice. So as a follow-up and reassuring.
Yeah. But no, I remember when you showed it at first, it did have some ugly features to it that at least gave you pause.
Yeah, for sure. On the day when I saw that, that gave me pause. And I
You got
called
a
him up
nice
and I
smoke
said,
artifact coming into the inferior vein too.
yeah, so we have a relatively slow flow, and yeah.
That's a pretty intense one.
Yeah. Good. Those are my cases. We're at the hour, so
Yes.
good.
Great cases. Thanks everyone, and I'll talk to you all next week.
Thank you.